factors, things other than our physical body affect what we think, do, and talk about and act all the time. So the definition that I took from the ASAM, this starts with just the definition of addiction. Addiction is a treatable chronic medical disease involving complex interactions among brain circuits, genetics, so think about those things being in our physical body, the environment, and an individual's life experiences. So right there already the addiction definition has in it the social determinants of health reflected in that definition. Definitions from a couple of different sources, just so you can kind of see the jargon a little bit more. The World Health Organization calls social determinants of health the conditions in which people are born, grow, live, work, and age. So these circumstances could be anything from your experiences in school, the distribution of money, how much money your family has. All these things kind of play into our health outcomes. And then the APHA is the American Public Health Association, and they too say social determinants are the social, economic, and physical environment factors that impact well-being, such as housing, access to healthcare, and employment. And how many people here see their clients as being affected by their housing, access to healthcare, and employment? Okay, so these things affect your clients and affect their outcomes and treatment. So some examples, there were some in the definitions that I just gave, but other research has a broader definition of what some of those social determinants can be. So they can include childhood experiences, biology and genetic endowment, gender and culture. And when we talk about culture, I remember from my days in prevention, there was a lot of research around, well, one example is just the culture of being in a sorority or fraternity in college, right? There's a lot of research that shows that if you're in some of those high-risk groups, that you have a higher likelihood of having alcohol misuse or alcohol use disorders. Another one, when our state was considering, our wonderful legislators wanted to decrease the legal drinking age down to 18, they cited Europe, and they said, gee, Europe, they start drinking at 16 and 18, and they don't seem to have as much of a problem. But when you really went into the research coming out of Europe, there was actually a difference between Southern European countries and Northern European countries. The researchers found that in the Southern European countries, such as Italy, alcohol use was usually in a family environment centered around a meal, and they did have lower rates of alcohol use disorders. But in Northern European countries, where there was, first of all, more cold weather, longer, darker days, the drinking was more associated with pubs after work, not associated with family nor a meal, and they had much higher rates of alcohol use disorder. So just in that research, you can see the influence of cultural factors in substance use disorders. This is just a nice chart from the Kaiser Family Foundation that shows some of the different social determinants. Debt, I see one under economic stability. How many people experience insane stress from having debt, right? And sometimes those stressors impact our behaviors. So other terms that you might be familiar with just working in this field, the socio-ecological model that's typically talked about in prevention, the public health model, patient-centered care, trauma-informed services, recovery-oriented systems of care, really kind of having that wraparound model, environmental prevention, all these terms relate to that aspect of social determinants of health, that we're not just curing a physical problem like a broken bone, but there are many aspects of our health and our environment that play into both prevention, treatment, and recovery. And I just threw up a couple of examples. Just in my experiences, again, working in a school system, learning challenges was probably one of the highest risk factors that I saw. I had students that had learning challenges. They were under stress every day. They felt like they were never able to be good enough in school. It was hard. They had a lot of negative feedback coming at them when they were failing in school. And that was a risk factor for a lot of kids that I knew. Early identification. If a family doesn't go to preventative health visits, there's a lower likelihood that they might talk to a primary care professional about some risky behavior or concerning behaviors early on. Treatment, cultural barriers to treatment. There are some cultures or language barriers that might impact the effectiveness of treatment. And then recovery supports, as I'm sure most of you, all of you know, social isolation can be a social factor that affects your recovery support outcomes. I'm going to skip this slide just for time. Actually, I have enough time. So this is, again, the World Health Organization. So now we're moving from kind of definitions and how it plays into the continued care to, what are some of our public health leaders kind of saying about what we should do. So the World Health Organization, again, underscores, we can't just treat the physical body, that we do have to consider social, cultural, economic, and other supports that affect health outcomes. And they definitely underscore poverty, how that impacts access to healthcare, financial stress in the family, and other aspects of well-being, that sense of well-being. And that these things at the very end, these can exacerbate behavioral health disorders. And how many people have seen that in the clients that they work with? Just being at a low socioeconomic level, it's stressful every day, just trying to make ends meet. The stress of having debtors calling you, it's stressful. So this is from the Journal of Addiction, a 2013 article. They looked at some of the outcomes of people in treatment, and they established some common risk factors. So those risk factors, again, other than the physical body, are having parents or family that uses substances, difficult parent-child relationships, physical abuse, emotional abuse, neglect, post-traumatic stress disorder, peer relationships, bullying, gang involvement, ADHD, and depression. So again, not rocket science. These are the things now that the researchers have found do increase risk for substance use disorders and increase the challenges in receiving and having success in treatment and recovery. This next slide is from a study in New South Wales. It was actually a really interesting study. And on the last slide, somewhere in the slide deck, there are the references that I cite. And it's a couple of the last one from the Journal of Addiction and this one are really good reads if you want to read up more on it. But they found that social cohesion versus social exclusion was a primary factor in health and well-being and treatment outcomes, as well as class, gender, and race. For example, people from low socioeconomic classes have poorer health outcomes, and they are more likely to drink alcohol in a high-risk manner and use illicit drugs. And then drug-dependent people are more likely to be unemployed and to experience marginalization, both of which exacerbate their symptoms and their problems. So again, we went from kind of where our public health agencies have gone in terms of defining these things to the actual research that backs those suppositions backs up those suppositions. So the health of drug users is inextricably bound to their social environment and a product of both drug use behaviors and social determinants. Housing is one example that has been probably researched the most and found to be have a high correlation. So public health approaches. You all are clinicians, but at that larger kind of aspect of public health, these are the things that make a difference. Decreasing poverty, increasing quality childcare, decreasing family stressors, increasing educational services, educational opportunity, meaningful employment. Those are big societal things, right? And to change them takes a significant investment of time and resources. So those are the things that we might change over 10, 20, 30 years in our society or in our state. Whereas the next ones kind of speak more to the clinician. So increase effective mental and behavioral health services and increase access to these services. And what comes up next is the importance of wraparound care. And how many people here work in a organization that provides that wraparound care to people receiving substance use disorder treatment? Okay, some of you, not a lot, not a lot though. All right, that's a smaller percentage than I thought. These are some of the individual things that we can do with individuals. Increase social supports. Think about talking to clients about, how is your housing, how stable it is, how, maybe recommend people for family communication skills training, but really doing patient-centered services, because every social factor is going to affect a person differently. So if I go back to my days as a public health teacher, once one of my students might, and these are stories that I heard directly from them, but they were in a family where there was a lot of substance use, a lot of alcohol misuse, and it was just something that they really kind of thought that was the way their family was, and that was the way they were going to be as they grew up, and that was a risk factor for them. Another kid with a similar situation would say the other opposite. I just saw what alcohol and drugs did to my family, and there is no way I'm going to be using alcohol and drugs. So the same risk factor is going to affect every person differently. And you know that working with your clients, that everybody's different. And so that patient-centered care is probably the most important thing that we can do in terms of considering social determinants. And I'm running out of time. So these are some of the best practices that SAMHSA and the Surgeon General recommend. Just focusing on treatment. Obviously, trauma-informed treatment is probably the number one thing that treatment practitioners should consider, and then care coordination. Having that wraparound caseworker approach to treatment and recovery support planning. So it's not just asking, how is your, staying away from using going, but how's the rest of your life going, right? How's the job? How's the family? Are you feeling supported? Are you isolating? Are you staying engaged with positive peer groups and things like that? The Surgeon General's report, that landmark report that came out a few years ago, said wraparound services are vital for successful treatment, including finding stable housing, obtaining job training, and accessing recovery support. So even the Surgeon General at that level is recognizing and underscoring the importance of social determinants of health. And I'm going to close with this slide. In some of the research that I did, just for the reading that I did preparing for today, one of the researchers actually talked about how helpful it's been to classify substance use disorders as a medical condition. That was a really big change, kind of a jargon change, not jargon, but a nomenclature change that was important for the medical community to recognize substance use disorders as a medical condition. And then the researcher said, but have we kind of moved too far in that direction of it being a medical condition and forgotten that it is a biological, a psychological, a social, an emotional, and a spiritual disease? And so if it's all these other things, in addition to being a physical disease, then we need to be treating all these other things, right? Supporting all these other things about the clients that we work with. And then I just, as a segue to Jonathan, I brought up the national outcome measures that you all collect and enter into the WITS data system. Those talk about things like housing, employment, incarceration, and things like that. So even that system that's been going on for, 20 or 30 years, recognize the importance of social determinants of health as well. So it's probably really exciting to actually see some of the WITS data. I know, I can sense the excitement in the room. So with that, we're going to have questions at the end. I will be here at the end of our section before the managed care organizations come in. So I know I kind of went fast, but there's a lot of good information, but ultimately not rocket science. This is something that's intuitive to all of us, but there's some things in research and maybe in some of our state data that can help us, consider new things to do in our practice. Jonathan.
Yeah.
Here's the clicker.
Yeah, exactly.
I made it a joke, but use the website if you want to.
I'm going to do it while he starts talking.
Great.
Because we should be practicing good public health measures.
We should. Indeed.
Yeah.
Exactly. Wow. Okay. I feel fully protected.
There you go.
That's 6 feet. Yeah. Great. So thank you. Yes. So I'm Jonathan Stewart. I'm also with the Community Health Institute, and to borrow the funnel analogy, we're funneling down a little bit more, and I'm going to be presenting some data that was just recently released as part of a study that was required by our state legislature. requiring the Governor's Commission, alcohol and other drugs to report to the legislature on cost effectiveness of substance use treatments. We started, so each year we're going to be doing some kind of a study as long as the statute is in place, and focused on one of the more expensive services that are provided. And in this case, it's clinically managed, ASAM level 3.5. If anybody here is from Farnham or Keystone Hall or North Country Health Consortium, essentially showing your data. Southeastern is in here a little bit, but primarily there's only really 3 currently active resources in the state for this level of care. So essentially that's the information I'm going to be providing. So it was a cost effectiveness study. I'm only, because of our topic today on social determinants, I'm focusing on the effectiveness part. I'm not going to bore you with the dollars part. I'm really focusing on the effectiveness. And bear with me because there's a really important take-home slide, about 4 or 5 slides in, that really relate to our topic today. But just some some framing of this. Our focus was on services that are paid for by the state. It's actually Bureau of Drug and Alcohol Services, so it's not doesn't include Medicaid. And I would encourage Medicaid at some point to contribute outcome information. There's claims information. It's not necessarily outcome information, but the WITS. If any of you provide data into the WITS system that EDAS manages, you probably don't often get information back from. You enter the information and nothing ever comes back. So right now, some of it's coming back finally, and I'll acknowledge up front it's a bit sloppy in terms of the data. We had a lot of challenges, making use of the data because there's a lot of missing information. There's a lot of differences of interpretation, but to the extent that the legislature is going to start requiring us to report on this, it becomes even more important to have a common understanding, good quality of data, and so forth. But given that, what we were able to do was we were able to identify 236 clients in the last fiscal year, which ended in June 30 of 2019. So 1 year, July 1, 2018 to June 2019, there were 236 clients that were paid for by BDAS that had 3.5 level services where in that time period, that was the majority of the costs that they incurred. They may have received other services, right? I mean, so there's a continuum, there's a step down, hopefully. So there may be other services involved here, but these clients are ones that in that year, the majority of their costs were 3-point level care. And there was a record of outcome measures, both from admission and discharge. And we lost a lot of clients because we didn't necessarily have both the beginning and the end. So we ended up with 236 where we could look at them. Oh, sorry. Here we go. So I should say, so the national outcome measures, there's 6 of them. And by national, that means these are things that are required by SAMHSA. When they fund states that fund treatment clients, they ask them to report back up on these 6 things, which are essentially no use of alcohol, no use of illicit drugs, no criminal justice involvement, employment or school participation, peer support participation, and housing stability. So people who are entering into the WIT system, ideally at admission and discharge, are making a record of these characteristics for their clients. And those were our outcomes that we were looking at. A little bit about the 236 people. Average age was about 38. About 60% of them were male. The referral source, the predominant one was safe stations, followed by individual, criminal justice, healthcare provider, and community agencies. More than half recorded that their substance abuse at admission, their primary substance, obviously there's polysubstance use, but the primary substance was opioids, followed by alcohol. About 30% of the clients identified alcohol as their primary substance at admission, and you can see the others there. There's the 6 outcome measures I mentioned. Here's 3 of them, and this is a complicated chart, but just to walk you through it, the green bars are essentially assets. Okay, so the dark green is people in this case who were using alcohol at the point of admission and were not using alcohol at the point of discharge. Okay, and that's true for all of these. The dark green means essentially a change from either no use of alcohol, moving to, or no use of drugs, moving to using drugs to move to no use, having some criminal justice involvement, which is essentially an arrest record in the prior 30 days, and then not having an arrest record at discharge. The red is where there's not an asset. So essentially, the lighter pink means that at admission, in this case, they were using alcohol, and at discharge, they were still using alcohol. The darker red means that they were admitted not using alcohol, but at discharge, they were using alcohol. So it's essentially a regression. So you can see how that plays out. Here's the other three that are more related to our topic of social determinants. You can see that there's very little change on employment or school participation, more change on people who moved to not being in independent living to being in independent living. And the biggest change was moving from not being in peer support to being in peer support participation at discharge. So here's the big slide. Yes, you have a question.
Yeah, sorry. So are you saying this research was done at the start of residential and at the end of residential?
Yeah, that's a good question. So essentially, the way WITS works right now is people record the NOMs at admission and at discharge from an episode of care. So within that episode of care, there could be other services that are provided. So it's not enrollment, disenrollment from a program. It's admission and discharge from an episode of care.
So it could be a Farnham step down to IOP step down.
Could be.
And when they left Farnham completely,
Right.
then we would have that discharge.
Right.
Okay.
Exactly. And that's a really important. So, I mean, ideally, the NOMs would be recorded at the point of enrollment, disenrollment. It's different levels of care. But right now, it's just admission and discharge. And so that's why we isolated by just looking at people who had the majority of their costs for high intensity residential, but other things could happen.
Yep.
Okay. So this is a lot of stuff on here, but what I want to put, so this is a logistic regression, where essentially we're isolating factors that are related to whether someone at discharge was either, there's two buckets here. 101 people went from using substances to not using substances. The majority of people didn't. You know, they were using substances and still using substances or regressed, okay? So about 45% of people were in that successful treatment outcome category. And what this table shows is what are the factors that are most related to being in that bucket of successful treatment outcome. At the top of the list is participation in peer support. And the odds ratio is about 7, meaning that all other things being equal, age, gender, substance, if you were participating in peer support, your odds of being in a successful treatment outcome were 7 times greater. Okay, so think about social support, social isolation, those factors that Lisa talked about. That's the top of the list. Okay, referral source was also about 4 to 5 times your odds of being in a successful treatment outcome bucket if you were referred by criminal justice, a healthcare provider, or other community agencies, so a structured system you had access to, your odds went way up again by a factor about 4 or 5. Living arrangement, housing stability, odds about 3 times. So compared to people who didn't have stable housing, your odds of being having a successful treatment outcome went up by a factor of about 3. Okay, and then things we would expect, like you completed treatment, or you were in treatment duration for 14 days or more, also had an effect, but not as great as these other things. So there's social determinants. Okay, so that's why I'm here. So I wanted to show you, this is data from New Hampshire from last year. It shows that access to care, essentially, or some kind of a structured referral, peer support, social support, housing. These things are more impactful than if you completed treatment. And things that dropped out, age, gender, primary substance, recent criminal justice involvement dropped out. I think probably because the referral source sort of masked that in a statistical sense. So take home, participation in peer support has a substantial positive effect referral from a structured system, professional organizations, also really important. And housing and discharge, very important. And my last pitch would be that the WITS data actually is useful if we all make use of it, and there's there are opportunities to make that more consistent over time. That's my spiel.
I'll just, you want to use the question? All right, can everyone hear me? Yes, you can
Probably
probably.
need the clicker.
I need the clicker. I know. Everyone else, you all know me too well. I get carried away with the clicker, especially does it have a laser pointer? It does. It doesn't work on screen though. So I'm super excited about today. I get like 15 minutes worth of slides and that's it. I get to learn and hang out with all of you. So it's kind of nice. Plus I'm leading them into a break, right?
Yeah.
Awesome. This is great.
Well, after questions.
After questions. All right. You have your time cards ready? All right. Good. So we're good to go. All right. So when we're talking about social determinants of health, what dimension are we talking about? Anyone who's been to other ASAM trainings? 6. I hear some 6s. I heard a 5. I see a 5. 5, 6. Okay. So really what we're talking about when we're talking about social determinants of health is dimension 6. Okay. You all probably are not very surprised to hear me say that ASAM was a bit ahead of its time when it came to social determinants of health. When we talk about social determinants of health, it's kind of the hot topic now. If you look at ASAM and ASAM research in the 2013 third edition of the ASAM criteria, they really have been talking about social determinants of health for a long time. So the way we can get things confused is when we talk about things like medical conditions. All right, we're not talking about dimension 6 when we're talking about medical conditions. If someone has a chronic medical condition, an acute medical care need, whatever it may be, we're really talking about dimension 2. I heard 2. Hey. All right, so we're talking about dimension 2. When we're talking about someone's difficulty with access to medical care or behavioral health care, what dimension are we talking about? 6. Now we're talking about dimension 6. So really everything with the social determinants of health really falls in this dimension, okay? So if we're doing an accurate or a thorough assessment of an individual, these are some of the things that we, I gotta stay still, I guess. I know. Maybe actually it's a new microphone.
Yeah, that's it.
I'm gonna change microphones actually. I also, before we get going too far, I do want to give a plug. So I was actually brought into the world of Jonathan on the evaluation piece with all that data, and I've never wanted to run back to clinical work so fast in my life. But the one thing that I did take away from all that, and I have to give this plug, is that WITS was really an obstacle for a long time, and I understand I get it without getting too far into it. I no longer work for Jamie, but we're still friends, so I don't want to make her mad. But the thing that I walked away from it is that the data that you put in is really important. I remember doing clinical work and kind of going into that going, oh, it's just freaking WITS thing, let me get this in here as quickly as I can and fill it out, as best I can without taking some of the time, because this is really what drives the care. So I just want to give that plug. When you're looking at WITS and you're overworked and stressed and you have to input that data, understand that data is important. Anyway, going back to this. So some questions you want to ask or some information you want to gather. Do any family members, significant others, living situations, or school or work situations pose a threat to the person's safety or engagement in treatment, right? So we want to find out what are some of the social determinants of health, or what are some problems in social determinants of health that could make it difficult for this person to engage in treatment. So if you're looking at outpatient services, right, for an individual, and that person lives with 4 other people who use, they live above a bar in a neighborhood that is rampant with drug use and sales of drugs, that is going to create a barrier for them, okay? They're also reporting to you that they really don't have a lot of skills to overcome their environment. They don't have any connection to any other sober support. So right off the bat that their social environment is creating difficulty for them. Their living situation, maybe they're involved in school and their school is in a high-risk neighborhood or whatever it might be. Another question, does the individual have supportive friendships, financial resources, or education or vocational resources that can increase likelihood of successful recovery, okay? So not only do we want to look at the liabilities that an individual might have based on the social determinants of health, we also want to determine what assets do they have, okay? They might not have a car, but they like to ride their bike. Or they might not have a car, but they live in Manchester, Concord, some area with a bus system. They live right around the corner from where they would receive treatment. There's sidewalks in their neighborhood. I know I've been learning a lot about the social determinants of health thing, and that makes a difference. If you live in an environment where it's not conducive to walking, you're less likely to be able to get around if you're not licensed. And I know a lot of our patients are not licensed to drive a car. So you want to take those things into consideration as well. Are there legal, vocational, regulatory, social service agencies, or criminal justice mandates? I would also add, are there social mandates? Everyone's a lot of times mandated by something, right? It's their wife, their husband, their kids. So there are mandates that may enhance a person's motivation for engagement in treatment if indicated. So I don't have a drug problem, I don't have an alcohol problem, I got a probation problem, or I have a problem with my kids or with my probation officer. That's okay, because we can build off that through motivational interviewing skills. But what are some of the mandates, or what are some of the motivational things that we can take into consideration when we are looking at individuals? Are there transportation, childcare, housing, or employment issues that need to be clarified and addressed? Okay, so if someone has transportation issues, but also they have childcare issues, okay, that can be a big thing. But what resources do we have at our disposal that we can kind of create more opportunities for that person to engage effectively in treatment? We don't want to say, yeah, this person's appropriate for IOP, but we don't have a plan, or they don't have a plan, or we haven't helped them work on a plan to figure out their transportation, figure out their childcare, and things like that. Same thing with housing. If we have an individual who has housing issues, we want to be careful that homelessness or housing problems in and of itself is not a reason to admit someone into an SUD treatment, right? But if that housing issue is tied to the reason that they are having continued problems with substances, now we're looking at low intensity residential, transitional living programs, things like that. But we also want to look at what housing resources. I know that's a very hot topic and something that needs to be bolstered in our state. But what other resources are at our disposal? Social determinants of health and the ASAM criteria. Assess patients' recovery environment according to the 6 examples of social determinants of health. So looking at those 6 examples that we have, we want to find out, we want to look at economic stability. What are their limitations economically? Okay. Do they have Medicaid? Have they enrolled? Do they have private insurance? Do they have resources to pay their rent? Things like that. Are these things going to interfere in the patient's ability to participate in adequate care? And that's really one of the things that we want to keep in mind. How important are these things in that they're not going to be able to engage in care? Thank you. Plenty of time.
For the first time.
I know.
You saw it here first.
I could kill 10 minutes pretty quick though. Still got another slide. So if we have an individual, let's say the person is coming to see us, and we know that they have some resources, they have some ability, they can do some kind of metacognition, they can kind of think about their thinking, which we know is really helpful for things like REBT and CBT and some of those skills. And we know that they're saying, yeah, I have some difficulty, but the other day, someone asked me to use, and I thought consequentially, I thought it through, and I did this, that, and the other thing, and I was able to come out of that okay. Again, we're looking at assets, not just liabilities, so we can determine that person, although they lack some recovery skills, we have a basis to work on. Okay. Also, that they have a lot of their friends use, but they've really been avoiding them, and they have this one friend who got into recovery and he's been sober 6 months, and he goes and hangs out with him instead. So we want to look at that asset. That's that social determinant of health piece. We know that they somehow always manage to get up and get to work. All right, they're able to sustain their employment, which is sometimes kind of something that we find, or I've found in the past too, is that the last thing to go is usually the cell phone. But before that, for a lot of folks, is the job. Because that's how they're funding things. That's how they're funding their habit, and they're able to function in that work environment. So we know that may be a social determinant of health we don't have to focus on. But their family is unsupportive and are disengaged, or they have very, very limited engagement with the individual and very limited understanding of addiction. So what we sometimes do is we invite them to family day, and when they don't come, we just kind of say, okay, instead of really kind of making that part of the recovery plan, engaging the family. So are the problems related to a specific social determinant of health driving the patient's need for care? So this is the other side of it, okay? So while we may have social determinants of health that are going to interfere in the person's ability to engage in treatment, again, dimension 6, are there problems in their social determinants of health that are really driving their level of care? Remember, it's important, and for those of you who have been to ASAM trainings before and are fairly savvy with ASAM, the level of care that they're at, the problem that made them appropriate for that level of care, okay? So let's say it's a residential setting, a low-intensity residential setting. Whatever problem made them appropriate for that level of care, the fact that they have been unable to sustain recovery because they haven't built a social network and they live in a really dangerous environment for recovery. If that's the problem that's driving their level of care, that should be the problem that is on the treatment plan that drives their care, okay? So that's where social determinants of health come in here. If their social network is a problem that is driving the level of care, that's an important piece to have on the treatment plan, okay? So if they are, inappropriate for levels of care in a lot of different ways, but they have that piece that is related to social determinants of health, that is the reason that they are at the level of care that they're at. That should be on the treatment plan. Does that make sense? Yeah. I can't stress that enough, because if you have like high intensity residential, the way that should be set up is that you're stabilizing imminent risk. So you're looking at things that could kill the person or seriously harm the person or someone else and stabilizing those things, okay? That may be outside of this a little bit, but it doesn't mean we don't address those things, okay? If it's not the driving force of the treatment plan, it should be addressed through case management plans and things like that. All too often we wait for the very end. We're like, oh, they're done their 16 sessions or whatever it is, and we really need to figure out what we're doing with them. They have housing issues, they have family issues. We're gonna write on the discharge plan that they really need to engage in these things instead of engaging them while they're in our care through case management plans and things like that. Treatment plan and recovery support. I think I've already actually kind of, through my pontification, covered a lot of this. If the problems related to social determinants of health is what drives the patient's need for a level of care, it should be on the SUD treatment plan. I think I already said that, okay? I can't stress it enough though. If it's a housing issue, a social issue, if it's related to, something related to their SUD, something that needs to be addressed at a specific level of care. IOP programs are great for folks who have difficulty building that social recovery network. We look at recovery support. Are they willing to engage in 12-step programs? Are they willing to engage in smart recovery? Are they willing to work with a recovery coach? Those are things that can be put on a treatment plan. Other social determinants of health determined to be of concern should be focused in case management plans. So again, not waiting until the person has completed treatment, working on those things as they move forward, okay? It might not be what's driving care. The person may have, they may have some interpersonal violence in their relationships. Maybe they have an abusive spouse, an abusive partner, whatever it may be. That may not be what's driving care, but that's certainly something that is a concern for the individual and should be addressed. Does that make sense? Okay. And it shouldn't be done at just discharge. This should be something that's actively part of that. Because if that person stabilizes whatever problem, thank you, stabilizes whatever problem made them appropriate for the given level of care, whatever other things are being continued to work on through other treatment plans, through case management plans, can be carried over to the next level of care along that continuum. Okay, so that person moves from a residential or a intensive outpatient program once they've stabilized those problems, but they still have this difficulty of the interpersonal violence. Okay, and they can continue to address that problem in an outpatient setting. Okay. That was my last slide. What time to kill?
Yeah.
I've never been here before. What do I do?
Take questions.
Questions?
And not just questions for you, but questions for
Yes.
Linda and Jonathan.
Yeah, we can get the other microphone going too. Yes.
How do people get creative with case management when a client has private insurance as opposed to?
So how can people get creative with case management when someone has private insurance versus Medicaid? Any suggestions, ideas? Some insurance plans do have case management. Yeah, and they can give you a list of resources. Absolutely.
Strengthening the contract between the insurance company and the treatment program.
Okay, yeah. So strengthening and revisiting, you know, if you're running in negotiation, like, hey, we have these folks who need all of these case management services that we need to get paid for. We want to help them. We don't want to have readmittance. We need to address these things now. Going back to the insurance company and having a conversation to say, you know, what services can we add? I think also looking at the services that you're providing and saying what case management services are we providing and what resources and what relationships or even MOUs can we make between our partnering agencies or the social services agencies in our area. You know, can we contact our local food bank to talk about food resources? Can we contact the local domestic violence shelter and talk to them about, you know, hey, can we work together and things like that? Yeah.
I might just add that, you know, if it's applicable, that if there is not a care manager or a case manager available, that looking at what would be targeted within such a plan and seeing if that's something that can be fit with peer support or recovery, like Jonathan was saying, like there's a lot of.
Just say that. I just want to make sure it's recorded on there. You can just say it again. Sorry.
I can't repeat that. I was just saying that if care management or case management was not an option within their plan or within their means, that focusing as part of that discharge plan, like what would be targeted within such a case management focus, and seeing if that's something that the peer support or peer recovery could assist with in developing more of an organic approach to hitting some of those targets.
That's a great suggestion. Yeah. Not everything has to be, you know, cut and dry, but they can work on those things. Just pass the mic back.
I was just thinking if it's not something that you can get insurance to pay for, all of the doorways offer case management, so you can refer to the doorways and they can help with all of those things.
Absolutely. Great suggestion. Yeah. Other questions, comments?
When we were planning this this day today, I actually had a question because I'm not a treatment clinician, and it's probably something that's already done. But is it helpful to talk to the client about, you know, the importance of addressing the social factors? You know, like they might. I'm just thinking of myself. You know, if I heard, gee, you know, really improving your social supports and not socially isolating has been shown to be, you know, really effective in supporting, you know, treatment outcomes. You know, so it's like it's something that I already know maybe about myself, but really kind of hearing that, you know, New Hampshire data kind of supports that this is actually a factor for a lot of people, and really underscoring the importance of, you know, whatever factor it is. I don't know. I just.
Yeah.
As someone who doesn't know the clinical world.
Yeah, that's a great point, and I'd love to hear more clinicians in the room chime in. My feedback would be, as long as it's done through a motivational interviewing kind of approach, instead of saying, listen, this domestic violence in your relationship, you got to leave this guy. We know that doesn't work, right? But beginning that conversation to say, you know, one thing that I've, and it all is based on your rapport. If you have very poor rapport or little rapport, or whatever with the patient, it's really difficult to kind of to shoot that arrow, as I like to say. But if you have that rapport and you're comfortable and you're getting the supervision to say, you know, one thing that I've noticed is, you know, every time you have a relapse or a reoccurrence or a flare up, as I like to call it, it's, you know, you've had this issue with your significant other. I wonder if we could talk about that a little bit. Yeah, you know, I just, you know, every time he hits me or every time there's a, you know, problem, I feel better when I use. And we allow the client to make that connection, you know, instead of saying, listen, I have all this data from the state of New Hampshire that says that you really need to leave that guy. You should go back to school. You should move somewhere with the sidewalks, and you know, there's some other things you can do. But you know, I just want to point, because I think it's an important piece to keep in mind is that we want the patient to understand that these social determinants of health can influence their outcomes, but we want them to come to the conclusion on their own. Do other people have other feedback?
I think about the isolation as a symptom of the whole disease. So talking to them about, you know, addiction, one of the symptoms is the isolation, and really exploring how that impacts them and how it impacts their feelings, and how the socialization is more kind of part of the recovery.
Yeah.
And like really exploring both of those pieces. And people seem to really get that as like, you know, understanding that, yeah, I don't feel well when I isolate necessarily, but there's this piece that keeps me safe, you know, and really diving into that a little bit.
Yeah. I mean, I'm going way back. I'm racking my 12-step brain, but you know, there's a story in the big book of Alcoholics Anonymous about the guy who puts whiskey in his milk. He thinks it's a great idea because he's thinking in a vacuum. You know, he's isolated socially. He doesn't have those relationships, and we know that if we have those relationships, someone may say, you know, putting it in milk doesn't really make it any safer. You know, so yeah, we want to make sure that people understand, regardless of what decision they're making, because it's all up to them. That you know, social isolation can be counterproductive to recovery. Certainly.
Yeah. Just like the piece of like secrets keep you sick. Like we explore a lot of that. Like what does that mean?
Yeah.
You know.
Mm-hmm. Other questions? Feedback?
I just have feedback on. I really like. It's not just medical. It's social. I think we've thrown way too much the way we get people come into jail. All they do is take this. The doctor gives it to them. They never go to a 12-step. They never go to a meeting. Never see a counselor. They're never going to get better if they don't take it as a holistic approach.
Absolutely. And if you look, I should have put it up here because that's a great point. I forgot to kind of mention that. You know, if you look at the longer definition, ASAM's longer definition of addiction, they really talk about that social, emotional illness. It's not just a medical thing. It's not just the physiological changes that occur in that pleasure pathway in the brain. It's how the behaviors and how everything else kind of affects them. Yes, we always swing one way or the other. It's like, oh, let's go over here, you know, instead of like finding a happy medium. So, other comments? How are we doing for time, man? Sarah in the back.
I sometimes find that actually talking about the social determinants of health is easier in the beginning, because when folks come to therapy, they're not always willing to dive right into some of the emotional and capacities. So actually starting at some of the social determinants can be really helpful.
Yeah. Good suggestion.
Any other last questions for Lisa or Jonathan or Paul?
The other thing I want to say is, because I mentioned, you know, when you have folks that come in and they really focus on these are the problems related to the substance use disorder. Sometimes you have folks that come in the other way. They're like, I mean, anyone ever seen that nail in your head video? I've shown it in trainings before. It's like, there's a nail in your head, like that's the problem. But they come in like, oh, the problem's my housing, or the problem is my relationship, or the problem is that I need to go back to school, or I need to get my license back. And meanwhile, you're like, well, you can't get from point A to point B without getting arrested. That might be your problem. So, you know, sometimes it's you know, helping them through motivational interviewing skills, through that, but it's still addressing the social determinants of health issues. Yeah.
Okay, so we're gonna take a break now to talk to each other, get some food, get some coffee. We'll come back at 10:15 and start that second part of the agenda with MCOs. And thank you to Lisa Paul.
I'm gonna pause the recording.
Hi, everybody. We're gonna come back now. Can you? Hi, everybody. So I'm going to introduce Dr. Sai Chirella from the Department of Health and Human Services. Dr. Chirella was so kind to join us kind of last minute, so thank you for that. She's going to provide us an introduction on kind of the direction, bringing this into the managed care organizations, how we're starting to tie the social determinants into the actual MCO contracts, why the state decided to do that, how they decided to do it, and then we'll turn it over to the MCOs to tell us the specifics about how they're doing that. So thank you very much for joining us today.
Thank you. Thank you for giving this opportunity. This is my favorite topic, so I'll make time for that. But I'm Sai Chirella. Basically, I'm trained as a medical provider, but most of my focus is on public health. That's my place to go, happy place. I work in Bureau of Population Health and Community Services in the Division of Public Health. But when you hear population health, everyone thinks the big P, the small p, the small minor piece. We don't know all the P's kind of thing. For us, the most important piece is we are thinking about population level. That means it covers anything. So it can be from your social determinants of health to mental health, behavioral health, whatever we want to call that. We want that to be wrapped on for the services for the people. So why are we here? As I said, we are from public health. We love numbers. So we have to tell you some numbers. Think about COVID response. We'll always talk about like the numbers of people that are infected or not infected and all that kind of stuff. So where will we stand on New Hampshire on our state of health? So every year there are rankings that happen, like they rank all the states by how they're doing, whether they're doing well or not. We have been in the overall rank in the 50 states, we are 6th in place. It sounds really great news, right? That's a really great news for all of us. And we haven't changed this rank from last year. That's also a very good sign. But let's say 6th rank, ranked 6, let's open a little more the numbers. What's our strengths? Our strength is we have low levels of air pollution, which is very good. Environmental health is very good for us. We have low infant mortality, that's also a good sign. We have high immunizations, that's very good. But we also have equal number of challenges. We have high drug death rate. When we talk about some of our differences in our health status, it's different by education. What level of education they attain that actually impacts what their health status is. And I don't have to tell you, high frequent mental distress. That's one of our challenge. The most troubling things from past 2 years and past like couple of years we have been seeing is our suicide rates are increasing, they're going up. And not only that, our obesity rate is going up. And for the first time in 2018, cardiovascular deaths actually became the leading cause of death in New Hampshire till in the last decade for the first time. Cancer was always leading cause, which we always understood it's age related and other things. But for the first time, cardiovascular death became the leading cause of death. And that kind of gives us a big cause of concern, like what is going on in the last decade, even with all the health changes, why we are seeing the trend. So with all this information, we start thinking about how do we put this information together when we think about social determinants of health. I don't have to explain social determinants of health. I think all the presenters before me had really did a wonderful job of putting together, funneling that information. So when I look at social determinants of health, I look at how we are spending our healthcare in all those social and those factors. When you look at the health of an individual, how much percentage of the health is dependent on those socioeconomic factors, those physical environmental factors, their lifestyle risk factors, and then the healthcare. Almost 80% of someone's health is dependent on all those other factors. Just 20% of that is dependent on the healthcare. Basically access to healthcare or quality of healthcare. So 80% is on those factors, 20% is on healthcare. Now I have a question for all of you. Where do you think our healthcare dollars go? Do they go to the 80% or do they go to the 20%? That's great news. You all know the answer. Just to give you the context, in 2015, US spent $1.65 trillion on healthcare. So 80% of that, almost 95% of that went on healthcare. 80% of that was spent on inpatient, emergency departments, prescription. And around 10% to around 15% of that was also spent on durable equipment, home healthcare, all those costs. Less than 5% was spent on the social determinants of health. That's the context where we are living. So this is where all this is happening. And these are some of the patients that you see in your clinics, in your facilities, who need all these services. When you think about all these factors, we always know that when you see a patient with a substance use, or you see a patient who is affected with some chronic disease, they have at least one unmet social need. And do you know how many of our providers really want to address that? Close to 80% of medical providers, behavioral health providers want to address those needs, but they don't have actual access to how to get to those services. So this is what happens. We know because these are the factors that result in high utilization of ED use. We know this causes them to show up as no-shows in our clinic. They are the ones who are associated with high rates of depression, high rates of chronic disease. We don't have to talk about, we all know some of these things if I ask you can pick up like the top 10 patients who have these needs. See, that's the answer that I'm going to say. So why Medicaid? Why should we pick Medicaid as our vehicle for addressing social determinants of health? Okay.
It's because it gets the right population.
Thank you. So when you think about social determinants of health and Medicaid, these are highly vulnerable populations. These are all the things that affect them in many places. When you think about childhood experiences, think about adverse childhood experiences. They might have come from families that had some kind of violence that impacts how how those experiences come back. Either has a chronic disease, or it might impact their substance use, or behavior health needs, or their mental health, those things. Think about housing. We all know many of our patients need those housing needs. Education, again, as I pointed out, our physical status is impacted by what their education attainment is. Social supports, many of them may not have the social supports, or they might have social supports that might be impacting them in a different way. family income. You pick any of these topics, these are the patients or these are the families. These are the ones who are impacted more because of these factors. So just to go a little more deeper, we want to think from Medicaid and how much of our population is covered by Medicaid. Close to around 15% of our population is under Medicaid, and close to around 70 as of January of 2020, around 70% of that population of our Medicaid is covered by MCOs, managed care organizations. So there is a strength in numbers for us to start thinking how can we impact those population and how can we do better for that. So starting looking at this, so we started looking at this as a bigger picture and started thinking about how can we impact and what are our strategies to kind of start thinking as social determinants of health in our MCO world, not only for MCOs, but also thinking from a whole department, how do we bring this together? So what are our strategies to integrate social determinants of health? So I just picked a few things so that we can start talking about it, but I'm also setting stage for our next presenter so they can go more detail about what they're doing around these areas. So one of the things that we have put in is screening. So basically identifying your beneficiaries in the MCO world or MCOs basically on what their kind of social determinant needs are, because that's our beginning of process to start thinking like, do they have some understanding? And most of the social determinants of health are cut across a lot of things. They can be housing, they can be social supports, transportation, talking about food insecurity. So these are some of the things that we have talked about or included in that. And it's part of that is they have to do an evidence-based health risk assessment tool that they have to use to develop those. Again, priority populations take priority. There are priority populations that need a higher kind of more screening. Those are some of the things that I thought. Again, thinking from a risk stratification, how do you risk stratify? How do you provide those services so that way you're thinking about that high number of people who have really high needs or frequent utilizers or whatever we want to call them in whatever format we want. Then again, embedding the social determinants of health into care management. Think about what are the social service needs that are there. Do you have those social support providers? And what kind of a referral loop, closed loop referral? Because not just referring them, but finding out if the person, the family, or thinking from a person-centered care, are these services available for them? Are these people utilizing those services? Are they in the right places? This also helps us to address our own gaps in the state or in our department to understand where the gaps are. Because we pretty much know there are many gaps in our social program, our social structure. So those are some of the things that we are working on with our MCOs. Then, local care management network. Again, thinking from that, most of the care happens locally. And we want the social services also to happen locally so that they're not traveling hundreds of miles to get some social care. So one of that is to focus on our local community-based organizations and developing our local, local care management network. And again, we are also using our quality improvement as well as our reporting requirements to understand where the social determinants of health lie, because we are asking our MCOs to report on how they have done, how they have provided care, where the gaps are, so that they could use some of that as a quality improvement for their own cycles to think about that. And also it's a PDSA cycle. Basically, we want to learn, we want to improve, and that's one of the ways. I'm not going to talk so much about medical loss ratio at this point of time. We are still working on that one. But there are also big pieces of that focused on training requirements. How do we train how do the MCOs train their staff around social determinants of health? What's our available resources? Again, this ties back to some of the questions you had around the care management or case management kind of thing, but that's another resource to think about. So these are some of our strategies to begin with, and we are learning as we are working. And just to give you background, the MCO contract started in September of 2019. And so bear with us, we just have 6 months of information. But as part of this learning process, the whole department is coming together. And it's not just the responsibility of Medicaid, it's not the responsibility of behavioral health. This is a whole cross-agency kind of work because there is so much overlap that occurs between all of us. We might see the same patient in behavioral health, they might be in the Medicaid, or they might be at the long-term services too. So we want to have that kind of an integrated approach to say, like, how can we do better with our, not only with our families, with our, that kind of a person-centered care. So this is my talk. Now we'll be talking with each of our MCOs will be presenting on how they are doing with the social determinants of health and what are the things they are working on their operation. Thank you.
So we're gonna start with AmeriHealth Caritas. I always have trouble saying. We did it this time. Thank you.
Just took my notes. I was gonna say that's the one thing that sets us apart from the other MCOs, that no one can say his name.
We only have 2.
You may be able to speak.
It's for the people on the computer, actually, so the speaker is close to where they're listening from. Just one.
So good morning. My name is Don McNally. I'm the medical director of AmeriHealth Caritas. I am the medical director of substance use disorders and mental health. I'm an addiction psychiatrist by training, so I will try to keep this as short as possible and let the people who are doing a lot of this work talk about this. But I wanted to give a brief overview because as we kind of put into motion that we're hard to say our name and we're the latest MCO to come in. And so a lot of people don't know about us. So if I can give a brief introduction of who we are, kind of what the culture we're coming from is and how we're working with our other MCO partners, because I know this is an important subject to actually all 3 of us. It comes up a lot and we kind of do this little tour together all the time. So we see each other a lot. So AmeriHealth, so what's important to me here is that we're trying to change the culture of this. As a company, we came from growing out of
89 North and US.
We're out of here. You can go already if you want. I thought I was being short.
Why?
Yeah. We grew out of social determinants of health. Did we call it that in the 1970s or 60s when we were started by the Sisters of Mercy in Philadelphia, who said, no one's taking care of people with all these issues. We're going to start our own insurance company. And this group of nuns, habits and all, did this, which is pretty amazing. And it kind of still permeates today in that we've always talked about social determinants of health. And I think why I'm talking and doing the introduction is that, you may say, what does this addiction doctor know about anything? You guys are the guys on the front lines of addiction, and I was also. And I can say out of those 11 states that didn't have Medicaid, I worked in 2 of those states, and I didn't like insurance, and it's not popular when I say that as I work for an insurance company. But coming to this and seeing how it can actually affect things is a lot different. So I worked in Maine. I ran an outpatient detox hub, and I was the janitor, I was the doctor, I was the therapist, and I was a case manager. And I know how hard it can be to sit there with people. You're working with patients or clients, however we want to refer to them, and they're coming in. I'm trying to treat them with MAT. I'm trying to get them into therapy to kind of talk through. No one in that moment, when they don't know where they're going to sleep tonight, where they're going to be, wants to do therapy. They don't want to talk about their meds. And I turned into a case manager. And it's hard because we went into this to want to help them. And so I'd be giving them food out of my drawers if I needed to, or calling homeless shelters and trying to get them. And then, okay, and by the way, here's your prescription. And I can't be 3 things. I can be 1 or 2 in those times. And people learn in different ways. We're going to go into some details in the 20 minutes or so we have, probably like 5 minutes left now. But I want you to take away from this that AmeriHealth, since this is kind of an introduction, that one, we want to be flexible and work with the provider community. So myself and Chris are always available to talk to. and to think about different ways that we can affect this, and two, that we have case management services, I know that came up earlier, that can take a part of that off your plate so you can be the therapist or a doctor or in the moment again. And I know that, you know, all three of the MCOs want to engage people in care management as much as possible. That is a common theme between all of us. So with that being said, we'll get into some details, but remember that part. And Chris, it's all yours.
Well, I think, yeah, thank you, and it is nice to see so many familiar faces. So I'm Chris Mulcahy. I'm the SUD coordinator for the plan. I also, like Dawn, come from the provider world and LADAC here in New Hampshire. But most recently was in administration and clinical supervision prior to this engagement here with AmeriHealth. So, the barriers, the challenges, things like Dawn was saying, you know, are still, you know, they're still apparent in my memory of trying to work with a patient or with a client at the time to get them the actual care that they needed, not just what the diagnostic criteria would suggest or what's on their treatment plan that the clinician's trying to work through. So, so my hope is that I'll go through some examples. That's the plan. Even though we do this type of show around New Hampshire, I have yet to master the following along with a PowerPoint, so I hope you can bear with me on that. But I also wanted to introduce Stephanie Dahlberg, who is our housing coordinator, and Allison Wilbur, who is, and thank you for referencing quality, because she's our quality improvement specialist as well with the plan. And so speaking to all of the contributions to working with social determinants is we have a pretty robust set of products, and some of them are commonplace, right, that we share with other MCOs because they're part of the contract, and others are just the AmeriHealth Caritas brand or the philosophy, how we see enriching them. And so sometimes we want to know whether or not they're working, and so quality helps to keep us accountable to that. And so hopefully I won't talk too long as well, and we'll give some opportunity to hear from Stephanie about the specifics on how housing is related, because people have heard of Maslow, right? Yeah, we kind of need to work from that level of shelter and those things. So let me see what's around the corner here. Okay, so I think that, you know, one of the things that struck me in listening to the previous speakers was, you know, all the ways that social determinants show up. And the one thing that I was holding on to was that it's also in the minutia of the conversation that you're having with a client. You know, we were having a nice conversation with Paul out in the hallway, and just talking about how the issue is not always the issue, right? The patient doesn't always present. They'll say one thing, but then we dive in and we find a whole host of other contributing factors, or what we would call barriers to treatment, or other, you know, Axis 4 at one time, or Dimension 6 now. And, you know, there's ways that we list all these things, but it's also in the minutia of the conversation. It's trying to call a patient because they missed an appointment, but their cell phone is dead, right? We know now that there's another factor there. There's a social determinant, there's a financial factor, there's a maybe a transportation issue. What else was going on with that? And so it's listening for what's missing. And I think that's one of the things that we do pretty well as a company. The two highlights that I gravitate towards with this slide is the nimble and the evolving. That we try to be light and fast, and we try to cater to the local market. So if I'm speaking as an AmeriHealth Caritas company representative, which I think I am officially in this capacity right now, you know, we sort of pride ourselves in all of these categories, but being a New Hampshire native, working in the New Hampshire line of business, and developing this product, we're only 6 months in, I like to gravitate towards the nimble and the evolving. And so what we think is going to be an influence, what we thought, right, may not be, and so we need to have that bear out. And that's only through data analytics and listening to our members, listening to the relationships that we have with providers, and being able to adapt. Make sense? Okay, you can save me at any point and ask a question, because I will just keep talking. So I think like Dawn was saying, that the core way that we manage the social determinants is through that case management. And I jotted some notes so that I would stay on track, so you can thank me later. So if we break it out into two sections, you know, or just two thoughts. One is the specific for the member, you know, and how we cater to them. And in the moment, like learning what their needs are, either that's through an assessment, through an algorithm, you know, that we have that might factor in whether or not the PCP is local. What is the distance that the member must have to travel in order to get to that medical provider? How many claims have come in? What are they for? Do those typically require a follow-up? Did it occur? Not just the literally like answering the question of do you have stable housing, but how did the other answers influence that? And so we let IT sort of help us to determine other rising risks and things, and how we use those algorithms help feed that rising risk category like we were talking about, to then work with care managers, with care coordinators, to then make outreach, to call the providers themselves, to call the treatment location, or you know, try to get in touch with the members directly to see what else is needed. And so that's one side. And I can go into a whole list of what those products look like if people are interested. But the other is anticipating the needs, right? So as we know that the travel is far in New Hampshire, treatment is few and far between for some locations. And so in order to access that treatment, you're gonna have to travel. And so we need to incentivize that. We need to make that easier. And so we have, you know, transportation services available. We do something called the Friends and Family Plan. People heard of Friends and Family? Okay, so we will reimburse as an incentive, right, for members, is we reimburse them at the IRS's maximum rate in order to attend their medical appointment. So anybody remember or know what that is currently?
58 cents.
58, yeah. So the same reimbursement that I'm getting for driving here today is what we're gonna give a member to get to their medical appointment, to get to their AA, to get to their follow-up, their specialist, whatever the case may be. So when somebody is in treatment, so the residential programs, we also have a pre-discharge plan in place that will pay for the family we'll pay for that transportation cost for the family to come on site so they can do a pre-discharge debrief with that facility. So think of, you know, an example of the member lives in North Country, but they had to come south in order to get the bed or get the treatment. They're going to go back into that natural environment, which was oftentimes the source of their troubles. We want to get the family involved in that planning process. And so allowing to alleviate some of that burden to get them there. There's also a host of other money and incentives and things that are available to them post-discharge that helps them to continue whatever, you know, treatment or whatever behaviors or, you know, patterns that they developed while they were in treatment to continue off-site, whether that be a gym membership or acupuncture, massage, maybe Tai Chi, I don't know. But in the moment, so those are that anticipatory thing, right? We have to sometimes remind people that we're a Medicaid provider and not a dental provider, right? Because we anticipated that dental would be an issue and we wanted to factor that in. And so I think that's another way of determining, you know, to assist with the social determinants that, you know, it's really hard to get to a job interview if you don't have that confidence or you're constantly talking like this because it's now developed into a habit and you want to get that treated, right? So we're enabling, you know, members to do that. How am I doing on time? Told you I can keep doing this. So.
I'll give you the cards.
I can't see them from there. I won't look in your direction.
Okay, here, 10 minutes.
So I'll leave you with the last one because there's multiple things, but within the care management realm, so we'll get a notification of admission, right? Because we know in the state of New Hampshire there is no prior auth necessary for SUD treatment. Nod your hands, yes, right? We know that. So we often find out as a reflex, right? We find out afterward that a member of ours has now sought services. And so sometimes those services, right, are costly. It might be an ED, right, boarding, or it might be some high cost utilization of services. And so we're getting that member, they're coming into our attention at a very expensive time, right? And so we want to kind of go back and do some reverse engineering. Or I want to figure out why that was or what other contributions there are going on to that member's life. And so we do have assessments. We do have the contact. We have a process workflow that we're going to make outreach. So upon that NOA, that notification of admission, we're reaching out to that provider. We're reaching out to that case manager or just the treatment provider, whether it be residential or IOP or hospitalization or something. And like immediately trying to engage that member right then and there and to address a transition plan. Not to force them out of treatment early, but so that we can get that ball rolling so that when day one post-discharge happens, we have a plan in place, right? So we can identify those needs early on. We have a whole workflow on how we do that. If other needs were determined, i.e. housing, right? She sits catty-cornered to me, and it's wonderful because we can just sort of tap each other on the shoulders and bounce some ideas off of each other for needs. So there's that on-site early intervention for transition planning, I think, which is a really key thing that we do. There's a whole host of other things within care management that go on, but I think that's one of the main takeaways that I would want to bore you with before I hand the mic over. But before I do, is there any specific questions that Paul might have?
So when we're coming from that lens of social determinants of health, this is great. How easy is it for your clients or your members to navigate this system, to put in for that reimbursement and things like that? Is that a fairly straightforward process for them? Because I know that can be a barrier for a lot of people.
It is straightforward for us, right? We go to the website, download the form, print it off, and you can submit it. The one-stop shop that we tell people is to contact member services, right? That's like the every door is the right door mentality. That if you could just start with calling member services, then that's the unsolicited call from us. That's how it can get the ball rolling. But if a care manager is actively involved in that, then you have my direct line, have my cell phone, you have access to me. Oftentimes people prefer email, right? And so we're able to engage that way as well. So I think we'll mail the forms to them. We'll get them out there. We also do on-site visits from an acute standpoint, or pre-planned. So, mom can't leave the hospital until they have a car seat. We'll just go drop it off. We'll give you a car seat and drop it off. So like it's little things like that that add up.
Thank you.
Yeah.
Hi, what's your market share right now with Medicaid?
Like
you're new to the.
That's an MD question.
You're new to the.
We're above projection, but
so we are the smallest of the three. There's about 180,000 members. There's about 180,000 members statewide. We are at about 16,000 right now. So that is why it's hard when I say no one knows who we are and say our name, is that we're still building that and trying to get out there with that. So we hope to grow with that.
Okay, good. Thank you.
I know we have another question.
Do you provide within your staff case management to a particular patient that has left like a residential program or IOP during that transition before they get hooked up in with a therapist or whatever their aftercare plan is?
Yeah, so the request that we have the partnership with the providers is that we get a notification of discharge as well. And so if we weren't able to engage at the time of the NOA, the admission, then we're making frequent contacts or at least attempts to do it on the back end as well.
So that can be part of the treatment plan, right?
It would be wonderful. Yes.
Is the transportation just mileage reimbursement, or do you have people that are able to go out and like taxi drivers to go and pick people up?
Yep. Yeah. So we do contract with CTS.
Okay.
And then I believe there's other conversations going on how that gets expanded, but the friends and family is what we found is allows at least a little more flexibility within the day, right? Because CTS isn't supposed to stop at dunks, but they do. But your neighbor can.
Or if there's like a medication to pick up.
Exactly. Yeah. It tends to be an A to B sort of transport, but then we've brought that question up about what do we do if that appointment, because it's non-emergent, right? But what if non-emergent turns into emergent? Because they're at a standard medical appointment, but they need labs immediately, right?
And I know this is something as the MCOs in general and the state, we're all working towards improving, you know, nothing's ever perfect, but we're working towards improving the transportation system for patients because it's a problem. If they miss an appointment in some places twice, which we know in substance use is common, they get kicked out of the program. It's not really going to help their social determinants nor their medical cause. So it's trying to fix those things together that we're all kind of working towards.
Yeah. So I do want to be mindful of the time and give Stephanie an opportunity just to share a little bit of the how we do housing, which I think is also a shared burden from from Scott as well and the other in Beacon. So here you go. There's no good segue. I don't have a good segue.
So, as mentioned earlier, my name is Stephanie Dahlberg. I'm the housing coordinator here with AmeriHealth, and my background's in social work. And as was mentioned, you know, by all the presenters today, housing is such a huge social determinant of health. I strongly believe that housing is healthcare, and you know, we can't expect our clients and patients to live healthy lives without stable housing. So I love that this was written into the contract. I work closely with the other two MCO housing coordinators, and together, you know, we all partner with the community. So the way I see my role is kind of twofold. So there's kind of the macro social work side of things, working on the higher level with community policy, coordination on that level, but then also I work directly with members and helping, you know, meet them where they're at, whether it be homeless, at risk of homelessness, or anything in between. And so on the community level, we work really hard to partner with all of the housing providers and the current housing systems in place and making sure that we're in line with all that and using that information and data. Data is so important to find creative solutions and how we as AmeriHealth can find maybe a creative solution to supporting the housing needs of our members. As we all know, housing is very limited. There's limited options right now, you know, less than 1% vacancy rate, and how much of that is affordable and not much. So we really try to work with our partners and find creative solutions because there's not much out there, never mind something affordable and safe. And then in terms of working, you know, directly with the members, I partner with our other case managers, and I do case management with our members around housing and supports, making sure that we're not putting people in an unsafe situation, but also, as I mentioned, supporting them where they're at, working on things like budgeting, what do you have for natural supports, doing our best to wrap around the member and meet various levels of social determinants of health. I'm proud to say, you know, I have a SOAR certification that's through SAMHSA, so helping our clients, patients, members through the Social Security application process and getting that expedited because we know, you know, many of our patients and clientele are trying to get some source of income and can't work for whatever reason. The SOAR certification helps our members get that expedited so they don't have to wait as long, and that will, you know, help them in the long term with housing stability, but also with their other needs and care.
I know we're probably getting short on time. If you want to just pop to the kind of the,
you want to see what else
detailed
is
stuff, yeah, you might want
behind the curtain?
to. One more. Go another. Oh. All right. So, you know, we'll get into some quick detail, but there are many programs that could benefit some of the individuals you're seeing, whether it be between the case management that we've kind of gone on ad nauseum about, and that you're going to hear from all three of us likely. We do have a Bright Start program for those who are expecting and also have substance use disorders, which is similar to some of the other programs that other people have. But we want to make sure these mothers and babies are getting the best care and have the best chance of doing well, both of them together. Two things that aren't on here that I think are really important when we think about social determinants of health is one is our Mission GED program. So we will pay and we will help members through GED. We've actually had a couple of people sign up because how can we expect people who didn't have that opportunity to have education to kind of move a bit further or get that next job or find better housing? We can't. So we have to start where they may have been left out before. So that is a program we offer. The other is, it actually is up there, is the recovery care team, which is kind of a flexible, mobile substance use team headed by that guy and me. And we try to partner with the local substance use treatment agencies, locations. So we do have close ties with Groups Recover Together in Farnham, where we're working to be on site there at least twice a month to engage with our members a bit more. And it also, we meet internally to see where there are gaps in coverage in the state, and not just for opiate use disorder. My background is actually in alcohol use treatment, but I ended up being in opiate treatment because it's whatever, it was the thing du jour for the last few years, and rightfully so. But I think we need to start looking at all these substances again. And so we talk about those issues, where there's gaps in coverage, and where we can affect the social determinants of health. And it's a multidisciplinary team of case managers, myself, utilization management, Stephanie's on the team, our community care manager, and we come together and see where all the gaps in social determinants are for specific individual for the sudden. So I think that's an important one. Do you think there's any other details?
No, I think that, you know, despite the company being integrated with behavioral health, you know, the recovery care team has become this thing that we wanted to take it a step further, where, you know, we had, you know, specific times, we have involved with that. We have provider network. We have, you know, examples from each of the departments that we get together and we look specifically within those departments, what are the barriers to SUD treatment, and coming up with, you know, plans to address those. And so some of that is, like Don's saying, is the community engagement and directly working with providers on site, making sure that the messages or the products, so to speak, of the plan are communicated to the members directly, so that they realize that there's more involved with their insurance, they have more available to them than just going to their doctor, filling their prescription, and going home. You know, that there's other benefits to it. And so we found that, you know, why wait for them to call the 10-digit number, find their Medicaid ID number, plug it in, talk to, you know, somebody in the member services line, you know, trying to work through it. Like, let's just tell them directly what it is, because they're in the process of using their benefits right now. Let's tell them what else they have. So I think that's kind of the spirit of it right now.
Yes.
Are you linked with the doorways or 211? So if a client calls 211 or goes to a doorway and says, I'm homeless, and they say, what insurance do you have? And then link up and work with that.
Got it. You got this.
We work really closely with 211. I can say, from the housing standpoint, and I know we do for all the other, because 211 is huge, right? So many different things you can call it for. I know, you know, in my role and all the other things we do coordinate closely with 211. And for housing specific, we actually just partnered and entered into a coordinated entry system for housing specific, so that we can help get members prioritized and all that. But yes.
And we do with other things. We meet with them regularly. They do provide case management services, as everyone knows, and so do we. So sometimes it's kind of who's going to do what, but we do engage with them. And we recently started engaging with which is a hard group to break into, the peer recovery respites and supports, and trying to see how we can support them, because, you know, as you guys saw the mental health consumer survey, that only 19% of people at CMHCs kind of utilize those services, and we could do better. And so we're trying to work with different agencies. I know most people, you know, all the MCOs are trying to do different things to affect that program.
Just to your point about just the complete lack of housing stock and Section 8 vouchers, you could be on a 5-year waiting list, subsidized housing. I mean, it almost seems like this, you know, Sisyphean task to try to get someone housed. And are there any efforts, maybe, you know, more at your level in terms of engaging the legislature around looking at this? Because it just, I mean, I've lived in New Hampshire a long time. It just continually comes up. The whole NIMBY, you know, I don't want it in my backyard, cage citizens against virtually everything. You know, I'm just wondering if you have any thoughts, or if that's part of the, you know, the culture of your organization to try to work with cities or, you know, community development block grants, things like that. More at the systems level, because I just feel like trying to get, I mean, I admire you for your job because it seems it's just like a really impossible task.
That's one of the really exciting parts of my job. I love that higher level, you know, the policy level staff, and I can say, you know, all three MPO housing coordinators, we work together with the state, but also, you know, going to advocacy groups, partnering with local departments as well. So yes, it's something that, you know, we're all working on, the whole housing community, you know, it's a big issue for everybody, so.
And we do have legislative effort towards that, and our market president generally does that, and then with any kind of sub-related or behavioral health related, you know, I can be brought into those and testify for what needs to be for the legislature. So it is a system task, and it's not going to be accomplished quickly. And I think just kind of chipping away in how to do that. And I think finally that there's been this movement. We've all known social determinants of health, like we said, been there forever, but that now it's catching up to insurance companies, hospitals, that how much of this is health and how much can we affect this and reduce costs by spending some money to do some of these things. It's a culture change that's not right.
I mean, I'm just curious, do you have any data, like how long it can take you to get somebody housed?
I can talk about housing and data all day. I love it. I'm happy to be, because I'm trying to be mindful of time, I'm happy to be present afterwards to answer some of those specific questions and talk more housing, because I love it.
Just a quick question. I'm a nurse care coordinator, so I do a lot of the work I think that your case managers are also doing. But my question is, so I've got a patient in my office. Is there a backdoor number that we can call that we don't have to sit there on hold for like 20 minutes waiting to get through the right person?
In my car? I can't answer for everything, but yeah, we have direct lines for all of our care managers.
We'll give you our card and, you know, we'll find out based on primary, you know, what the need is for that member. We would have it go to the, you know, the right care manager.
Yeah, that's perfect. It's just like I said, sometimes we just call the main 800 number.
Yeah.
And it's like first you listen to music, then you listen to a recording, then you press this, and then you enter the patient's, you know, ID number, and then you wait, and then you say, this is what I want. All right, hold on, let me get you to the right team member, and then you hold. And it's like, you know, I've got 50 patients.
Yeah.
You know, I'm spending an hour on the phone with each one of them.
Any other questions for AmeriHealth Caritas? Gotta say it like that.
I've heard of Carnitas. Do you name it? I messed up in interviews sometimes. So.
Thank you.
Thanks.
Next up, we'll have New Hampshire Healthy Families.
Thank you. Hello, everyone. There we go. Hi, for those of you who don't know me, my name is Andrea Rankatori. I'm the Director of Behavioral Health with New Hampshire Healthy Families. Scott, do you just want to introduce yourself?
Sure. I'm Scott Wellman. I'm the Housing Coordinator for New Hampshire Healthy Families.
So Scott and I are doers of these programs. We're not presenters, so just bear with us, please. This is not our forte. We like doing this stuff, not necessarily presenting it. So really, in terms of New Hampshire Healthy Families, we recognize, and these are items that have been talked about, right? Access to care, workforce, and obviously we're here for social determinants of health as to reasons why, you know, we found that we need programming that really supports our members and addresses these needs. Sorry, these are visual slides. See, I'm not even used to this. So really there needs to be a strategy involved in this, right? It's not just one component to make these things successful. It's really about looking at operations. It's looking at, you know, the different programs that we could offer, and then having community engagement, right? And so everything you guys have to offer members and as providers is important and invaluable. And we want that feedback, we want that information, and we've used that as we move forward with what we're going to present in terms of what programs we've developed and what we've done around social determinants is thanks to you all. So this is just some of the programs that we have in place. And again, besides the basics of care management, transportation, things that have been talked about so that we're not duplicative, I'm focusing a little bit more on some of the unique programs that we've developed as New Hampshire Healthy Families. And one thing I want to highlight is the Certified Recovery Support Worker, the CRSWs. Folks know who these super important people are in our worlds, right? What we found is back in 2018, March, I want to say there was about 63 CRSWs in all of New Hampshire. And as John, thank you so much for sharing data on the value of peer support. We recognized there was an opportunity to really help build this workforce. So what we did, actually we'll just move forward. So what we did is we decided to partner with several organizations throughout New Hampshire that were offering CCAR or the Academy training and sponsor individuals to get their training that's required to become a CRSW. And then also mentor folks through the process, because that can be daunting, right? Understanding what trainings you need, getting connected with volunteer employment, finding out how you do your background check and test your exam prep materials. So really mentoring people through that program and then helping them connect with employment. And so today we've supported over 100 CRSW candidates through sponsorship or mentorship. And we currently have 9 candidates that have graduated from this program. So 9 of these individuals have received their CRSW and are employed in New Hampshire. In addition to this, we also partnered with AmeriHealth, AmeriHealth, where are you? We want to partner with you guys, with the AmeriCorps program and Harbor Homes to sponsor folks to complete their exam. And we have 12 of those individuals that just passed their exam, yay. So again, adding to the number of CRSWs in New Hampshire to do this very invaluable work for peer support. So Ready for My Recovery is another program that we started and launched back in September with our new contract. What we recognize is that we have what's called My Health Pays. And I don't know if folks are familiar with that program, but as our members engage in healthy behaviors, it could be going to a doctor's appointment, it could be getting their flu shot, they earn dollars on this reward card, okay, that they can then go to Walmart and use on all kinds of toiletries. They can actually use it to buy things to pay for rent and fuel assistance and dental work, whatever they want to use those dollars towards. But what we recognize is that we didn't really have anything for behavioral health. And so we advocated very strongly internally to get a program that does just that. So this program, actually, if people enroll in it immediately, and I don't know where the slides are, and you'll see it later, they get a backpack filled with items such as a self-care kit, water bottle, journal, earbuds, all kinds of items just to help them along the way for their journey for recovery. But then as they engage in treatment or recovery services, they can earn dollars on this card. Today we have actually more than that. We have about 85 folks that are enrolled in this program. And about 62% of those folks have made it through that first month reward. So that means that they've engaged in treatment for at least that first month. So that's tremendous. We're super excited about that. Because again, it's really about helping people to initiate their treatment and engage in their treatment, right? Stay in treatment. Oh, so here's the backpack and then the rewards that they can earn throughout the way. And really the first year of the program, they earn these dollars, but then post the year, all they have to do is attest to the fact that they're continuing, whether it be in peer supports or they're continuing with 12-step programming, smart recovery. They just have to attest to that, and then they can continue to earn those dollars. So in addition to that, we have other things that we've been doing. For instance, we have a campaign that we've launched. It's called I'm Ready. And there are these wonderful little wallet cards that have all kinds of important information on the inside, all important contact information. And what we really wanted to do is kind of, again, going back to stigma, really support both members, consumers, providers, any family members, anybody who's ready to do something in order to address substance misuse or substance use disorder, social determinants of health, all of that. And so I have a bunch of stuff that people, if you're interested in having some materials, we can hand them out after. Just a few other programs. Oh, sure.
How do you go about the enrollment of this program?
The Ready for My Recovery?
Yeah. Oh.
So, because every program's different. So I can give you my contact information,
Okay.
so I can definitely help you.
Something that they just go online?
Yep, they can go online. We have the form online. They can contact myself directly if they'd like, and we can mail them a form if they don't have access to online. Super easy to enroll in any of these programs. So in terms of partner outreach, again, and I don't want to be duplicative, but we too have worked since even the safe stations obviously transitioned to hubs. When it comes to social determinants, I remember going out and meeting with folks really early on and then saying, we just need waters. We need bottled waters. We need, breakfast bars. Is that something you guys can do? And it was like instant. Yes, that's totally something we can do. And that's just progressed, right, in terms of what we have offered and are able to offer. And so again, New Hampshire Healthy Families, we want to know what would be helpful for the folks that you're working with, because it might be something that we could partner on and help you all out with for our members. Okay, so now I'm going to turn it over to Scott.
So I'm going to talk a little bit more about our social determinants of health programs that we do have, and I'm going to start with the housing coordinator position, since that's what I know best. So it is in the new contract. It's a dedicated staff to address the needs of members experiencing homelessness, at risk of homelessness, or need added supports and resources to minimize the impact of housing issues on physical and emotional health. So housing is the biggest thing. I've been doing this I've been working in mental health for 35 years in inpatient hospitals, state hospitals, community mental health, and I've been here. And I know that the biggest issue that people have is housing and finding a place that they can really call home and be stable and be able to address those health needs, be able to address the needs that are going to keep them stable, either in health or with maybe their substance use issues that they have. And so it's imperative that we do this. And I know that Stephanie mentioned that we work together, all the housing coordinators, we work together with the state. There's a lot of initiatives out there that we're trying to work on. And I think that given time, there will be some cooperative efforts between all healthcare organizations throughout the state to try and provide housing in some way for our people, because without housing, they come to the emergency rooms, and we know that, and so it costs us a lot of money. So housing is such a huge piece. One of the things when we first started going to meetings and talking about the housing coordinator positions, everybody's eyes just lit up, and everybody's like, oh, great. Someone's, no. We didn't come with little houses in a truck or buildings all over the state, unfortunately. But we are that person that one of our members can call and get that support. And we identify who those people are through our assessments, through our care management team. And who are these people that are at risk, or maybe are homeless currently, and what have they done? How can we be that advocate for them to help them to find housing, help them to start that process, because some people don't realize that they may be eligible for Section 8. Now, unfortunately, we have to tell them that it's anywhere from a 3 to 7 year wait. So let's get started now. Or maybe they've applied in the past, but they just haven't checked up on that. And so we have to do that. We have to make sure that we check on that, because if they apply again, all of a sudden, instead of being 20th on the list, they're now 100th on the list. If they've applied before, they've already been in the list, their most recent one will be their date. So we have to help and try to work with that. So I go out in the community and speak with our members. I'll help them fill out paperwork if necessary. I'll work with any provider in the community that needs some help with that. So there's a lot that we do, and I love the work. And as we said, the inventory is low, and that's probably one of our biggest issues. And then, you know, with a good economy comes, and with all this building of all these high-end apartments, property values go up, rents go up, and then it's not affordable for anyone. So, you know, we have a lot of barriers to overcome to provide the housing that's really necessary. So that's my spiel on housing. And I'll be around for a while afterwards if anybody has any other questions. Whoops, what did I do?
Sure.
My button dummy.
Let's see, it's still here. Is this what you wanted to do?
Yeah. Is it which button is it? The top one?
The side, right?
This.
Yeah.
Okay. Here we go. I must hit the other button. So one of the things that we did here in the last year for transportation to address transportation needs, we co-sponsored a new van to transport 100 plus resource center members in the Tilton, Greater Tilton Area Family Resource Center to their sub-treatment each week. So we provided a check to go towards this van. I think there was a number of community sponsors for this, but we were one of them in order to just, again, address in a small way, a small area, that need for transportation. And I think these are the types of things that we need to try to work on throughout the state any way we can. And you know, it's a good start. We're working on that. We have self-care kits, the little black bags with washcloths, soap, shampoo.
All alcohol free.
Yeah. If they do have alcohol, we take it out. It's all sitting on my desk. And nobody wants to take it. So we do that. We provide that for people. We go to shelters. We'll provide those to shelters. We had some with us. I brought Stephanie and I were both down in Nashville for the pet count, the point in time count, and we had some available for people during that outing. So those are some of the things that we're doing. We gave the Great North Woods Foundation a check for $5,000 to help support the low-income people, to assist them with medical bills, housing, food assistance, that type of thing. Those are some of the things that we do throughout the state to try and address these needs. We have a Green to Go van. I don't know if anybody's ever seen that. We go to areas of the state. In the warmer months, we started just the end of this last summer with fresh fruits, vegetables, and those areas where there's food deserts, and trying to help people to at least stretch their dollars a little bit. And the people that come, they're not always just our members. It's anybody in the community that has that need, and we're there, and we do that. And what's great is throughout our company, throughout New Hampshire Healthy Families, all the departments have an opportunity to be part of the engagement team, which goes out to meet our members and be able to see them in person and meet them and talk with them and provide these types of resources for them. And then we have our great sock giveaway. We partnered with Bombas Socks. Bombas is a great company, very philanthropic company, and they gave us 6,000 Bombas socks, and we've been giving those away at every event, and going to the shelters, and going to, we've had them for we do work with Head Start programs throughout the state, and we bring those for the kids because we have the small sizes and that type of thing. So we've had a great success with that. So those are some of the ways that we're trying to respond to the SDOH issues, and how New Hampshire Healthy Families is trying to address the needs of all of our members.
And just one more piece. So we also have, I know we're getting great training today, but New Hampshire Healthy Families, we have a catalog of training that for our providers is at no cost. We have all kinds of trainings. We do have a training specifically for social determinants of health. So if you have organizations that you would like additional training on social determinants of health or any other behavioral health topic, we have a whole catalog here, and I can give those out to you guys. Just let us know, and we're happy to come to you. We have webinars, but we can also do in-person trainings as well. We'll come to you. Thank you so much. See how we ran from that?
Yeah,
we ran.
You were like, And we're all set. But if there
Question,
are.
oh, no, we do have a question. Sure. The green band? Oh. Sure. So we haven't, but again, that there's not to say we won't. I think it's about, you know, us knowing where there's a need and then having an opportunity to partner with, you know, a local organization to then maybe make something happen. So if you have any thoughts or ideas, are you with a particular organization or?
Yeah, I'm with Midstate Health up in Bristol.
Okay, sure.
We just started an IOP program up there. Really a whole lot of services for name.
Well, thank you for starting that, number one. And yeah, I can give you my information and we can connect after this. Sure.
Thank you. Okay. Beacon Wilson. Where did the clicker end?
Oh, I left it up there.
Okay, thank you. I'll just wipe the clicker over you real quick. Oh, here's my agenda. Wondering how I got lost. There.
So hi, my name is Carrie Coy. I'm the Director of Account Partnerships for Beacon Health Options. And with me is Kim Gorin, our Substance Use Disorder Coordinator. We're here representing WellSense. So WellSense is one of the incumbent MCOs. And they, Beacon, so WellSense manages the medical benefit, Beacon manages the mental health and substance use benefit for WellSense. We're co-located, we collaborate very closely together. It's more of a partnership than a vendor relationship. And so, you know, with these kind of complex members, we're working together, both Beacon and WellSense together to address these concerns. So I won't kind of go over this, we've kind of reviewed this above before, but, you know, social determinants of health, you know, like it's been mentioned earlier, it accounts for 80% of population health outcomes. So obviously it needs to be addressed. It's a huge factor. So for WellSense and Beacon, we are assessing every member that comes to us for social determinants of health. So whether it's through the health needs assessment or a comprehensive assessment, we're ensuring we're asking those questions so that we are identifying what the member's needs are. Although we might outreach a member because we think they need to manage their diabetes better, that member may think that housing is an issue, and that's where we're going to focus on for them. So there's, you know, different ways that members come to us in our care management team. There's ways that we try to identify that high-risk membership through our algorithms, and those are, you know, when a member kind of hits that high risk, we are outreaching them and trying to engage them in care management and trying to assess what their needs may be. Member and families can refer themselves, providers can refer them, anybody can refer to us, and we are going to outreach that member and help that member through whatever their needs are. So WellSense and Beacon has a very robust care management team consistent of care navigators, community health workers, social care managers, nursing care managers, housing coordinator, care managers specializing in mental health, and our SUD coordinator. So we kind of have a wide spectrum of different specialties. And again, we all collaborate closely together. So members high medical needs, social needs, and mental health, you know, we've got 3 care managers. We're working together. We're saying who's point and ensuring that we're not duplicating efforts, but in really ensuring that that person is getting that whole person care approach. So for every member that is referred for care management and accepting care management, we do a person-centered care plan. So after we do a comprehensive assessment, we are identifying what the member is looking for, what there it is. So they are part of the development of that plan. And also, you know, if they have connections with providers in the community, we want them to be part of that plan as well. We want everybody to be working working on the efforts to kind of obtain the goals that the member has identified. We share all of the person-centered care plans with the PCPs as well. And again, if there's other providers in that member's kind of care team and the member gives us permission, we would share that care plan as well and involve you in those discussions.
Okay, so we, WellSense has been part of the state since I think 2013. So since that time, we've been doing care management from the beginning. We've really built those relationships with some of those community services in the community, so we know where to link members to. We have contacts. We can call out and say, hey, we have this member, can you help us out? So we have a lot of those resources available for our members. And members remain in care management until their needs are met. So we're not just saying, hey, here's a number, call, good luck, and closing the case, right? We're helping them call if they need that. We're following up. Did you attend? How was it? Is there additional needs? So again, we are following through the continuum until they feel like their needs have been met. Do you want to take this on?
So I'll introduce myself for those of you who've met me. You know that I probably met me in a provider quality management role, which is that we were focusing on the providers in New Hampshire and making sure that they're doing good quality care. My other piece of that is working with our members and making sure, like Carrie mentioned, that we're working on sort of their whole health and then the whole person and finding out what they need and working with WellSense and our community providers, whether they're in or out of network, to get them resources that they need to help, if we can, eliminate the barriers to working on their recovery and accomplishing whatever else they need to kind of, again, work on that whole health piece of their life. So again, working with a member, like we've mentioned before, sometimes they're not looking at their substance use disorder as their primary need, and so working with that and saying, what is your primary need and how can we kind of fit this in, and just continually having those conversations. There's a lot of follow through, so not only finding out, do they go to the appointment and how is the provider, but then are you working through your IOP program, or how are you doing in residential, meeting with the provider, talking to all the different members. So it's just a lot of involvement. It's like Carrie mentioned, it's not just kind of here you go and sending them away. It's follow through and making sure that they're doing well.
And really we want to partner with the community providers. So we don't want to kind of be doing our piece while you guys are doing your piece. We want to be part of that kind of care team for that member. So we are always asking our members in care management, do you have providers? Can we contact them? And if so, can we kind of ensure that we're all working together on the same goals and really not duplicating efforts? That's the other piece. We have there's care management out there in the community resources. You guys as providers are providing a lot of care, and we just want to ensure that the services we're providing is augmenting all the services that you're providing and complementing them. And so that's really our goal, is to kind of have this more collaborative effort with the provider groups for these members as they kind of work through recovery. And then there's other ways that we can address the social determinants of health outside of care management, and these are some of the things that we are working on as the MCO. So value-based payment models of care that allows for a capitated agreement where you get a little bit more money so that you have more, so that you're getting paid to do some of those kind of non-billable services that you guys are already doing. So part of the contract requirements is that we start to enter into value-based payment programs with more providers. So we are currently kind of on that pathway and moving forward with that. And I think that, again, that allows for the providers to be able to address those social determinants of health through that. Integration. So, another big goal of the state is to enhance integration among the system. Certainly kind of having medical and behavioral health providers work together is great, because then you're all on the same page with that member's care. Right now, a lot of it can be siloed, where PCP is kind of handling something but not really talking to you guys that are treating the substance use piece. And so, really that can be difficult for one if the PCP isn't even aware that there's a substance use issue and could be prescribing things that are not appropriate. But also just not, just the collaboration and ensuring the members getting the same message from their treatment group. So again, we're looking to kind of identify some providers that we could kind of work towards and moving them along the integration stages to kind of help support that. And then again, training and education. So, we're happy to come out and provide trainings for any specific needs that you guys might have. You just need to kind of reach out and let us know. And that's all really we have. I mean, again, a lot of it's been said. I didn't want to repeat a lot of the housing coordinator. We have that position. So thank you both for speaking to it. The 3 MCOs are working kind of collaboratively on a lot of these initiatives, which I think is a great thing. It's the first time that, we have had this collaboration going forward. So I think it kind of helps move the system along. I'll pause there. Any questions?
Any questions for any of our MCOs? Yes.
Hi, I have a couple. From a provider point of view, maybe an outdated question. However, my understanding is when a new company comes in, or sometimes there needs to be a re-enrollment application process to be a provider, are they still 3 separate applications for each insurance company, or can there be a movement that's 1 application that goes to all 3 or 5? Because that is so laborious and time consuming when I'm redundantly doing 30, 40 pages of the same information. And the second question from a client's perspective is, when the client has a renewal period, is there a resource for the client to be able to see the different insurance programs to see what, because what I heard was similarities but differences, so that the client can actually research it and pick the insurance company that's going to best fit their needs rather than an automatic renewal piece.
So Sandy, I definitely hear you.
Hi, how are you?
Definitely hear you and lots of other people around that 3 separate application piece. It's something we continue to discuss at the department and with the MCOs. And then certainly during open enrollment, clients are able to go in and look at what is offered by the various MCOs. I don't know that we've ever done sort of a side-by-side comparison. I'm not sure that that's something that's easily doable because the 3 have very different options and benefits and ways of doing business. But it's fun. So the other thing that I wanted to just quickly address was Chris's comment about prior authorization. And under the managed care contracts only, so not private insurance, nowhere else, just managed care, the MCOs are prohibited from doing prior authorization or utilization management if the course of treatment is determined by a clinician who is trained in the use and application of ASAP. So that's that piece. The other piece of that is, though, that does not preclude the MCOs from doing their normal quality assurance, fraud, waste, and abuse monitoring, and bringing that back to the Department of following up. So I just wanted to clarify because I think that's not always clear to folks. So.
Thank you. I just wanted to kind of follow up on the last question. From a client perspective, we've heard a lot of, we're pretty similar, we're doing a lot of the same things from the 3 MCOs. And it's kind of a 2-part question. The first is, given that coverage is primarily based either on income status or employment, coverage shifts from time to time. So if we're talking about truly patient-centered care and doing what's right for the individual, the first part of my question is, if they're moving from one plan to the next, one company to the next, how much are you transferring information in that shift so that they're not starting from square one again? And the second part of my question is really around the idea that kind of by definition, we're talking about a population that has diminished capacity. They have further burdens from chronic disease and social determinants of health. And so a lot of your programs sound fantastic. I'm just wondering what kind of eat your own dog food testing you do before you launch them out to your members to be sure that it's really as easy to access your programs as you think it is.
I can speak, but I'm sure that someone's way better closer than I am. Anybody?
Yeah.
I think in terms of the first one, and correct me if I'm wrong, but transferring information, I know that there is a standard, I think it says 6 months of claims data is transferred from one MCO to the other. Anyone can step in and correct me if that's incorrect, but I believe it's 6 months of claims data. For the continuity of care. So, we do see, prior hospitalizations and medication bills and things like that.
Well, what about this stuff like the forms that a client would have to fill out, right? Are they starting from scratch with enrollment forms and that kind of thing? Or are you moving those demographic pieces of how much onus rests on the member who's already disadvantaged by chronic disease and social determinants to kick that ball rolling all over? That's kind of
in terms of eligibility for Medicaid specifically, or to determine which,
product to next, or one program to the next.
like from a Healthy Families to Marital?
Yeah.
Okay.
Or let's say they got better for a while and they were covered by a commercial payer, and now they've relapsed and they're back into the Medicaid system.
So I will say that the MCOs for this new contract did get together with the state and standardized, for instance, the health risk screening assessment for kind of some of that purpose, right? That saying like, to be redundant, or you're asking one thing, we're asking something different. So we're working towards standardizing a lot of the forms and a lot of the processes to help with that, right? That burdensome piece. So I think that's important to know here. I don't know if there's anything else, but that's, I think this, and even us being here today, right? So recognizing like, we want to work together. We want to make it as simple for providers and for our members, right? Providers too, for navigating this, even though we are 3 separate organizations, really trying to work together to make it as simplistic as possible for everybody. And we want to help. So if you have a member that's struggling, and you don't have time to help them, understandable, let us know. And then that's where our care management folks can come in and member services to help support that member and walk them through that. So they're not having to do it alone.
Yeah, and just to follow up on the second question that you had in terms of vetting our programs, I think that oftentimes the plans, at least that we're rolling out, have been plans that we have augmented for New Hampshire, because they're active in other lines of business within the company, and then we adapt them to New Hampshire, or they're specifically tailored to a request from the state or a theme that we're seeing from members or providers and stuff. And so, they are almost front loaded by the request, so it's built in. But I think we're constantly assessing the quality of the program, the engagement, the retention. You're looking at all of those things to see. We don't want to just be, I don't think any business, anybody wants to just be putting money out there into a program that's not going to be effective or is underutilized and things like that. So I obviously open it to how you guys do it, but I think it's pretty similar.
So we're almost nearing the end of the day, so thank you all. Let's do a round of applause for all of our presenters. So I did just want to provide a little bit of space for a little more discussion, if you have it in you, to see if anyone had kind of like successes or lessons learned in managing either, social determinants of health broadly for their clients, or working with the MCOs and some of these new benefits, or even just in the past, if there have been things that, you know, you and your offices have been like, oh, we figured that out now, that's really great, please share. So is there anybody that has a lesson or an aha, or it can be hard to think positively, but I encourage us all to do so.
I also wanted to add, if anyone, you know, in addition to those things, has like a, I didn't know that, or I plan on going back to my practice and kind of doing this as a result of this discussion, like, you know, what are some of those maybe aha moments that you had today?
So our clients are not covered by insurance when they're incarcerated, but we try to refer them or we'll sign them up and they can go activate. But we never knew about the housing because we don't deal with it. So for us now, we can say, hey, you can go call your insurance company you choose, you can go and maybe have more assistance than they would have otherwise.
And I'm just excited to utilize you guys. I didn't realize how much you offered, and I don't think my team realized how much you offered. I'm coming from the Family Health Center, so we definitely could utilize all of you. So I'm excited to get your cards and start working with you a little bit more.
Anybody else? Great. I'm gonna follow up with the MCO presenters today and see if they're okay with me putting their contact information in our Q&A document, because that's where Hannah's been capturing all the questions that you did ask today, all the answers that they provided to you today, and then we'll also make sure that they look that over to make sure that all the answers were captured correctly. And so I'll see if we can also include some contact information in there for any follow-up questions. I think I just have a couple more slides. So the community of practice will meet 3 more times in 2020. We meet quarterly. In case you didn't know that, that was our schedule. These are the dates: June 5th, September 4th, and December 5th. I believe it's the first Friday of each of these months. And the location is TBD, but usually it's in the Concord. It's always in the Concord area. It's usually here. It's just I can only book this space 60 days ahead of time, so I can't tell you for certain it will be. But it's in the Concord area. Last time in December, we were at the Conservation Center. If you didn't come, there was a Christmas tree and a wood stove, and it was lovely. So stay tuned. Sometimes we're in really fancy places like that. And then, oh, I don't have my slide where I want to talk about your evaluations, but that's okay, I can still do it. In your packets, you have an evaluation. Please fill that out. Hannah's gonna head to the back of the room and check off your name. So your evaluation is anonymous, but let her know your name when you pass it in, so she'll check off for your continuing ed credits, so we can get you your CEUs. There, please return your name tags as well. And there are 3 hours of CEUs for this event, so be sure to turn in those evals. We love your feedback, and we use it to plan the next meeting. So thank you everyone for coming. Have a lovely day and weekend.
Hey, if you ever get read a book, I like it.
I just noticed.
Yes.